Hello, everyone, and welcome to the Arthritis Action Podcast. I'm Marc, your host for today, and on this episode, I'm joined by Dr. Nick Fuggle. Nick is an associate professor in rheumatology at the University of Southampton and the Alan Turing Institute Clinical AI Interest Group co-organiser. Hello, Nick.
Hello. Lovely to see you.
Thank you for joining us today. Really appreciate it. So, artificial intelligence, or AI, is a very hot topic at the moment. It seems almost daily that there's a new story about it and how it's being used. But I mean, what I had known previously was how AI was being used in regards to arthritis. So I think this could be a fascinating subject for us to talk about. And today we're lucky enough to have Nick to explain this to us, essentially. So, Nick, could you tell us a little bit about yourself and what you do?
Yeah, absolutely. So I spent some of my time doing research, and that's mainly at the MRC Life Course Epidemiology Centre, which is a centre that focuses in on musculoskeletal diseases and looks at how they change across the life course. So that's all the way from babies through adolescents, adults, and into older age, and how musculoskeletal diseases change during that time. And then I also work as a consultant rheumatologist at Southampton General Hospital, seeing a whole gamut of different rheumatological conditions.
Wow, a nice full schedule then.
Absolutely. Yeah. Keeps me busy.
Excellent. Brilliant. So let's dive into the topic. So talking about AI. So, I mean, in regards to the context we'll be discussing, can you give us a kind of a brief rundown as to what AI is and the role it has in the treatment of arthritis?
Absolutely. So AI is essentially an umbrella term for the grand vision to produce machines that are as intelligent as humans. And this was a grand vision that dates all the way back to Alan Turing and his early work, even prior to the Second World War, which is, of course, where he became famous in cracking the Enigma code. And it's interesting looking back at that early work because he wanted to produce a machine which was able to essentially think like a human and devise this thing called the Turing test, which was essentially when you have a human and a computer and they both sit an examination or set of questions, and then there's a third entity, which is a tester. And if the tester can't tell the difference between the answers given by the computer or by the human, then the computer is said to have passed the Turing test, in that it's thought to have intelligence that is equal to that of humans. So AI is really around that sphere. It's around intelligence. It's around that kind of performance. It's not robotics.
I've heard about the and read about the Turing test before. It's a really interesting thing. One thing I don't know though, actually, is how often does an AI pass the Turing test?
Oh, what do you mean by that? As in
that the tester can't tell as to which one is human.
Yeah, I mean, I think even long before the most recent developments in large language models or GPT, for example, there have been algorithms or models that have been able to pass the Turing test. So it's not cast iron discriminator of artificial intelligence as we now understand it.
Okay, great. So why did you choose to study in this area?
I first became interested in it watching a TED talk, actually, back in about 2015.
Okay.
It was a TED talk about computer vision, because I'd heard about the fact that computers were able to look at images and be able to do things like spot cats. And I had just no idea I couldn't even conceive how a computer would be able to see a cat in an image. So I watched this TED talk, which was really interesting. It talked about supervised machine learning and some of the, what were then, I guess, relatively early facets of computer vision. And that's how I became interested in it. And thinking about the way that it could be deployed within healthcare. Then, of course, there was the early work by the DeepMind team and Google in producing models that could operate within mammography, or machine learning models that were able to identify risks of acute kidney injury in patients. And really, it's spiraled from there.
Cool. So how does this fit into arthritis then?
So there are various different ways that machine learning is really the kind of statistical process by which artificial intelligence is achieved, or one of the statistical processes. And it's probably worth at this point just explaining a little bit about machine learning. So it's automated. So let's say you had an algorithm, and an algorithm really is just a simple set of instructions that could be anything from what to do if a lamp is broken. So if the lamp is broken, then check that the lamp is switched on. And if the lamp's switched on and it's still not working, then check the fuse and then check the bulb. And if it's not working, then consider buying a new lamp. So that would be just a set of instructions. And of course, you can program those into a computer. So you can tell the computer to do those different things if a lamp wasn't working. But what machine learning does is it devises those algorithms, those sets of instructions on its own, in order to take some kind of input and turn it into an output. And there are different kinds of machine learning. So there's supervised machine learning, which is where a good example of this, it would be data set, which is, by a data set, I just mean, a collection of data. And if we were to take shapes, for example, and if you take in supervised machine learning a group of shapes that have been labeled for the type of shape that it is, so triangle, square, hexagon, and you show those via computer vision to some kind of statistical model that then begins to recognize the features that would be associated and match the label that has been given to it to the appearance of that shape. That is called the training set. And then after that, you then take a test set, which doesn't contain any labels, so just has shapes and no labels. And you ask that same model to predict what the label would be based on the appearance of the shape. And you can then adjudge the performance of it. So that's supervised machine learning. Unsupervised machine learning looks for patterns within data. So, for example, if you were to take UK Biobank, which is an enormous data set of genomic, physiological, questionnaire data that are taken from 500,000 people in the UK, and you were to say, okay, all of these people have got osteoarthritis. Find the features that are associated with osteoarthritis. The unsupervised machine learning would then go into all those data and look at different features that might point towards a diagnosis of osteoarthritis, for example. So automatically looking for patterns in data. And the third kind is called reinforcement learning. And this is thought to be the most similar to the way that humans learn. Mm-hmm. So this and the best example of this is probably self-driving cars. So you start with an agent, which would be a car, and then you have an environment, which might be all of the streets in London between Buckingham Palace and Wembley Stadium. And the aim or the goal of the car is to get from Buckingham Palace to Wembley Stadium, self-driving. And the environment inflicts different states onto the agent, onto the car. And so that might be weather conditions, that might be traffic, that might be cut-off roads. And what happens is that every time the car gets a little bit nearer to Wembley Stadium, it gets a reward. And so it then starts to make decisions in terms of turning down certain roads that mean that it gets closer and closer to that, but avoiding some of the environmental factors. So maybe avoiding some of the traffic, and thereby gets closer and closer and closer to Wembley Stadium. So those are three types of machine learning, really. So supervised, unsupervised, and reinforcement.
Okay, so could this be used, say, like for example, the diagnosis of arthritis? Like if you'd input like all symptoms and all like possible like trajectories it could go for arthritis into, say, an algorithm or something, then you would be able to decipher what's going on with a person. Then,
Yeah, so exactly. If you were to take osteoarthritis as an example, in a supervised machine learning model, you might take X-rays of people who have got maybe normal looking knees, and they look normal to us, then label them, for example, with whether they developed osteoarthritis in 10 years' time, and train up a model that can then look at an X-ray and then give a 10-year risk of developing osteoarthritis of the knees based on the appearance of a knee X-ray. So that would be a potential example of the use of supervised machine learning in identifying, early osteoarthritis.
and that could, in theory, then be applied to all different types of arthritis as well. Then,
Yeah, it certainly could be. I suppose at this point it's probably worth also mentioning how computer vision works. So, if you think about, let's say, a black and white image of a bone, and think about what the computer is actually seeing, because the computer doesn't actually see a bone. What the computer sees is more like pixels, black pixels where the edge of the bone is, and white pixels in the middle, and then maybe, let's say, white pixels around the outside.
mm-hmm.
But actually, for whenever there's a pixel, and this is a black and white image, it's actually assigned ones and zeros, depending on whether they are black or white pixels. And so actually, rather than ending up with a kind of pixelated image, for every place that there's a pixel, there's actually a number which is related to an intensity. And so you've got 0 and you've got 1, and then if something's grey, then it's somewhere in between. And so you can use those numbers in order to try and identify mathematical patterns within the image. And it's really that way that the computer sees a cat in an image, or it identifies risks on an image that might be associated with the future development of different types of arthritis.
Interesting. So, I mean, so how does this affect like the research side as well? I mean, is it? I assume it's currently being used in research as well.
Yeah, absolutely. So, computer vision is really one of the lowest hanging fruit in terms of the deployment of machine learning and artificial intelligence in healthcare in general. So if you're to look at, a regulator like the FDA in the US, the vast majority, over 90% of the AI tools that have been approved for the use in healthcare are related to computer vision, are related to deployment within radiology. And that's partly because there are enormous data sets of digital images that may contain information that we're not currently identifying, and could be used in order to improve patients' care. So in our own research at the MRC Life Course Epidemiology Centre, we've been working with colleagues in electronics computer science in order to try and identify features on certain types of scans that might be associated or discriminate people who are at a higher risk of fracture in the field of osteoporosis.
So what are the positives that this kind of brings to the treatment as well?
So one of the things that you want to really do is use some of these large data sets in order to try and personalize your approach to patients. And obviously in rheumatoid arthritis, we're now very blessed to have a number of different medications that we can use. So if one particular medication isn't tolerated or isn't working, then we can switch to a different disease-modifying anti-rheumatic drug, whether that's a conventional so-called DMARD, or whether it's a biologic DMARD. But one of the brilliant things would be if we could actually, rather than giving someone the medication and then waiting to see whether it has worked or not, because sometimes these can take months in order to show whether they're working effectively, if we could predict which medication was going to work for which patient, then we would be able to personalize our approach to that patient, get them treated more quickly, get their condition under control so that they can have improved outcomes and live, a better quality of life even quicker.
Excellent. So it's almost like it's kind of giving recommendations as to what the doctor could be prescribing.
Yes, absolutely. Yeah.
So that definitely sounds like it'd be very valuable for, so maybe like, a GP or whoever, rheumatologist who doesn't specialize in a certain one, it would just add an extra layer of expertise to them.
Yeah, so that's one of the key ways that AI could be deployed in healthcare, is in order to enhance the performance of maybe more junior colleagues or clinicians who don't have as much experience in a particular area, but it acts as a kind of supervisor. And it's really important at this point to just mention that humans need to be in the loop. Though we can't, and I think we're a long way away from AI operating independently. And any decision that is made using an artificial intelligence tool is the responsibility of the clinician that's looking after that patient. So clinicians need to not only understand it well enough for their own comprehension, but well enough that they're able to explain it to patients, explain the way that it's influencing their care so that patients are then adequately consented for their use. And at the Alan Turing Institute in the Clinical AI Interest Group, we're developing a suite of educational tools. We've held a summer school this year for clinicians who are interested in artificial intelligence, teaching them about the basics of artificial intelligence, the ethics of artificial intelligence, and some of the ways that it's being deployed presently in healthcare, so that we increase that educational level. And there's also work going on at Health Education England also around this same area.
That was one thing I was going to touch upon as well, is like, how do you kind of toe that line between the human interaction and like the nuance of how a doctor would approach something to the computer thinking?
Yeah. Do you mean the interaction itself, the kind of communication skills element, or how you actually include humans within the decision-making process?
I suppose how you then, maybe perhaps how you decide when the computer is right or wrong, if you know what I mean. Because a computer could say like, oh, prescribe this, this, and this, but if the doctor doesn't feel that's correct, how does that kind of situation work out?
Yeah, I mean that's where clinical judgment really comes into play, and where you need to know how the artificial intelligence tool is deriving its answer. So a good example would be within osteoporosis. There's something called the FRAX algorithm, and this is used to look at osteoporosis risk, which is obviously relevant to that condition, but also highly relevant to rheumatoid arthritis and other inflammatory arthritis, or anyone taking steroids for any reason, as that increases the risk of osteoporosis. And what the FRAX calculator does is it takes a number of different parameters. So the person's age, their sex, their weight and height, whether their parent had fractured a hip, whether they're taking steroids, whether they have had a fracture in the past, whether they've got rheumatoid arthritis, whether they've got other obvious causes of secondary osteoporosis, and also whether they drink 3 or more units of alcohol per day on average. And that can be supplemented with a measure called bone mineral density, which is taken from DEXA scans, in order to provide a 10-year risk of hip fracture and of major osteoporotic fracture. And so when that risk percentage is given, that's used against a threshold for treatment to decide whether or not someone requires anti-osteoporosis medication. But as a clinician, I can see that although it's very good and it's excellent on a population level, there are some things that the FRAX algorithm doesn't look at. So these are being added into newer iterations of FRAX. But for example, a person's falls risk, because obviously if a fracture is a combination of bone fragility and an accident of some kind, be it a fall or or some kind of a fall onto a hip or a fall on an outstretched hand. Those are the things that go on to develop it. So someone's falls risk is intimately related to their fracture risk, but that wasn't incorporated into the early iterations of FRAX. So although their overall fracture risk according to FRAX might not reach a threshold, if they're at very high risk of falls and they're on the borderline, then the clinician might say, actually, this has been really helpful information, but together with these other risks, I'm going to use my own expertise and say, actually, I think you would benefit from treatment in this case.
So how far can this go? I mean, is there scope for like AI to replace certain roles in healthcare, and are there sort of some roles that essentially are safe and could never be replaced?
It's a great question. I think that the standard response to that question across the field is that AI won't replace clinicians, but clinicians that use AI will replace clinicians who don't use AI. And I mean, even earlier on today, there was news breaking about work going on at University College, which is a team using a computer vision technique in order to identify different structures for neurosurgeons performing pituitary surgery. And the AI has already seen 200 procedures, pituitary tumor procedures, which it would take a surgeon 10 years in order to see and perform. And so the studies from that are showing that it improves the performance of even experienced surgeons, compared to those who aren't using the artificial intelligence. So I think it'll be used to improve performance. I don't think there'll be any replacement yet. And I think it's again, just to emphasize, it's crucial that a clinician needs to be in the loop.
Is this something that's now being included into like training medical students as well now? Is there like, an AI component to their learning as a mandatory field now?
Yeah, that's a really good question. We're actually doing a piece of work at the moment at the Turing Institute's Clinical AI Interest Group around an overarching curriculum for artificial intelligence. And that would include at medical schools. And in Southampton, this year, we're running a clinical AI special study module as well that will be running for our medical students. So it's definitely entering the curriculum. There's definite interest and acknowledgement across the medical education community that this is a field which is growing, and that the doctors of tomorrow need to be well trained in.
So is it like widespread now where it is everywhere, or is it some places are doing it more than others? Or?
I'd say some places are probably doing it more than others, okay. But it's definitely on the increase. And I think that at national conferences, it's on the agenda. So I think everywhere is aware of it.
Interesting to see what that's gonna bring to the future.
How it'll manifest.
Yeah.
Marc, can I ask you a question?
Yeah, of course.
So what would be your feeling if a clinician was to say, okay, so an artificial intelligence tool has told me that this is how I need to treat you. Let's say that you were a patient with rheumatoid arthritis, and that you said to me, which medication do you think I ought to use? And I say, I'm just going to ask the artificial intelligence. It said that you should be on methotrexate, for example. How would you feel about that?
Good question. I think you're the first person to ask me a question on this podcast. I think personally I would be fine with it. I think you kind of answered it for me in a way, like earlier on when you mentioned that I would be happy with it as long as there is kind of the supervision and the experience of a human doing it as well. Like I'm happy for the answer to be given out, and then like I would ask the doctor, like, do you agree with that?
Yeah.
If they said yes, then I'd be absolutely fine with it. But, if you get that one where they kind of give you a look, like a little side, like, I'd go a different route. Go, well, let's maybe go for your one then.
Yeah.
But then it also might possibly depend on who the doctor was, for example.
Yes.
If some people all give off like an aura of competency so much better than others. And, if it's someone who seems confused throughout the whole process, I might take the machine's answer.
Yes. Okay. Yeah.
But let's
No,
I'm making doctors sound bad here. Like,
no,
obviously,
no, no,
vast
no.
majority are great, but if
It's
I think there's the factor of both of them I would have to weigh up in my head.
well, it's interesting you should say about that kind of confidence element. There was a really interesting study earlier this year which took Chat GPT. And I think most people will know what we mean by that. But just for the uninitiated, GPT stands for Generative Pre-trained Transformer. And it's something called a large language model. So it's been trained on vast swathes of the internet and has essentially learned to produce language and answers based on the information that it's gleaned from there. And what you can do when you've got this thing called a large language model is you can bolt on different applications. And so one of them is called ChatGPT, which I'm sure everyone or a lot of people are now familiar with, where you can type in questions and you get answers back. And what a group in the States did was they took questions from the website Reddit. Do you know Reddit, Marc?
Yeah, no, Reddit. Yeah, so it's basically a message board.
Exactly. Yeah, it's a message board, and you've got different streams on there. And there's something I think it's called Ask Doc. There's an Ask Doc stream, and in order to be someone who can reply to a question on that message board, you have to have been certified as a health professional. And so different people put up different questions. So it could be, my mother's got osteoarthritis of the knee. What would be the best treatment recommendations for her? And then a clinician will write an answer underneath. And so what this team did was they took a selection of these questions and answers from clinicians, and then they took the questions and they just put the questions to ChatGPT, and then took the answers from ChatGPT and took the answer from the clinician, and then showed both of those to some blinded clinicians and asked them to grade those answers based on the efficacy of the clinical information that was being given, and also the empathy that was displayed within the answer. And what they found was that not only did ChatGPT seem to perform better when it came to the clinical accuracy, but more worryingly was that it was more effective when it came to the empathy displayed within the responses.
That is not the answer I was expecting to hear.
No, it's not. But there's an important caveat here, because that was the headline, was that ChatGPT is more empathetic than doctors. I think if you look deeper into it, and if you look at some of the answers on Reddit, you can see that it's an answer that isn't being delivered by ChatGPT. Because for a start, ChatGPT wouldn't make grammatical errors or typos, and yet there are some typos in the responses that are given by clinicians. So whether it was truly blinded, I think there are probably biases there, but it was certainly an interesting and thought-provoking study and a thought-provoking finding as well.
Definitely. I will also add, just for anyone going on Reddit for their medical advice, it may not be the best place in general to go, so do talk to
Definitely
your doctor.
Go to your local rheumatology advice line.
Absolutely. Cool. So last question for this one. Can you give any current examples of AI treatment for arthritis? Because I mean, one thing that we do actually at the charity is we work with an app called Good Boost, which is basically like a therapy app, exercises. I don't know if you've heard of that one or not.
No, I haven't actually, but I'll certainly look it up. So AI can be used in a few different facets. It can be used for identifying people who are at risk and trying to catch them early. It can be used to help clinicians make decisions about treatments. But it can also directly be used as therapy. But the ways that I would have thought at the moment that would be deployed is through things like cognitive behavioral therapy, for example. Okay. So in people who are, suffering with chronic pain, fibromyalgia, chronic pain from any possible condition, cognitive behavioral therapy is helpful, and there is a strong evidence base behind its use. And certainly one of the first applications to be given NICE approval was an application called Sleepio, which was to help insomnia, and had a cognitive behavioral therapy algorithm that was driven by artificial intelligence. So I think that is probably the field. What was the one you Good Boost?
Good Boost. So again, it also involves AI in the sense that it gives you like a set of exercises and things doing based on a set of questions that you'll answer, like how are your knees, where's your pain, where's it affect you, how is it? At the beginning of each session, it'll then ask you what your energy levels are, and so on, and then it will adapt a personalized workout for you, and then sort of give the person that, and it will then learn, like at the end, you get to review each one. So if you don't like certain things or aren't capable, then in the next workout, it will give you one that will exclude those. And it's really good. So we run sessions twice a week via that. So should anyone listening wish to do these sessions, you can get in contact with us and we can sort those out for you.
Very good.
Just done on your phone or tablet.
Very good. Check out Good Boost.
Yeah.
And do people have to pay for it?
Yes, there is a small charge to it, I believe. You do get some sessions for free. So it's not it just depends on how many sessions you do as to how much you're going to end up paying for it.
Great. But
yeah, definitely worth looking into.
Very good. And can people find it on the App Store?
Yes, on the App Store. You're doing my job for me here, aren't you? Yeah, you can find it on on the Apple Store and on Google Play as well.
Great. Brilliant.
It can be found in some leisure centres as well, because there's a pool-based element to it. So there's some waterproof tablets that some of the leisure centres that do have it, you can then sort of do it in the pool with your tablet on poolside and then do a water-based workout as well. So there's some really interesting things a lot around it.
And it watches you doing.
It doesn't watch you. It will just it will give you an animation to teach you how to do an exercise.
Okay.
So for ones like that, you will still have a facilitator in the swimming pool. That's mostly for health and safety reasons.
Yeah.
But it will basically give you an animation to follow of like how to do a sit to stand squat or something like that. And then at the end of it, you can tell them how you felt about it, like if you liked it or if you didn't like it, and then it will then choose whether to put that back into your workout the next time. Yeah,
very good. Sounds excellent.
Yeah, so it's really interesting to hear that AI is being used in so many different avenues.
Yeah, I think that will only increase. But we just need to make sure that the foundational challenges are addressed. And it is worth mentioning at this point that there are issues with that can be issues with bias. So if, for example, you in a supervised training set in machine learning, which I talked earlier about shapes, if you only do it, if you train it up in humans in only certain populations, then the algorithm will only really operate to the same performance level if it's looking at exactly that same population. So let's say it's a UK population, and then you try and deploy that tool in an African population, the performance may well not be as good. And so there's another very good interest group at the Alan Turing Institute called the Health Equity Interest Group, and their focus is really on trying to ensure that artificial intelligence is a mechanism which acts to reduce health inequalities rather than to exacerbate them. And that is a really key foundational challenge that we need to address as we move forward. And that I'm pleased to say that there is lots of work going on in that, and actually lots of grants out as well for looking at that particular area and trying to address that challenge. Excellent. That's great to hear. Brilliant. Well, is there anything else you would like to plug or to mention or anything you would like to part us with? No, it's been a real pleasure, really thought-provoking, and a hugely enjoyable experience. Excellent. Thank you so much for joining us. And if you would like to find out any more information about arthritis and all the stuff that we do at the charity, including Good Boost as well, of course, you can visit www.arthritisaction.org.uk, and do feel free to send us an email if you have any questions or any comments or anything at all. You can send that to
podcast@arthritisaction.org.uk. So thank you so much, Nick, for your time. I really appreciate it.
Thank you so much. No, it's been hugely enjoyable.
Excellent. Thank you. And thank you, everybody. Bye-bye.
Bye.